And it is indeed my honor to be here this morning. When Amelia first told me about the format that we were going to use for this year's keynote, I got so excited as someone who has spent a lot of time really looking at translational research and feeling the missed opportunity when we have so much great information available to us, but oftentimes that information and that research doesn't get translated or applied in real-world settings so that it can make a difference and be a strategy in individual lives. So this morning, to my knowledge at least, this is the first time of bringing together in this type of format the science and the real-world impact of Alzheimer's disease and related dementias. So with that, I want to start by introducing our guests, who I'm so happy to be able to not only introduce to you this morning, but so grateful that they're here. First of all, Tom and Ann Kerrigan. Back in 2011, Tom started to notice some cognitive changes, and these changes included difficulty in finding his words, short-term memory problems, and some challenges with math. And this was unusual for him, so he knew something wasn't right. And after seeing his primary care physician and a thorough neuropsychological workup, Tom was diagnosed with early onset. Originally, they thought, his physicians and the diagnostic team thought he had FTD, or frontal-lobe temporal dementia, but it was determined that it was early onset, and now at the age of 48, Tom and his wife Ann, who are parents to two young kids, they shared with me they have two kindergartners, so they are going through a significant change, of course, as they look at how to keep their family on track based on this shift that's happened for them just in the last couple of years. It's also my pleasure to introduce Dr. Huntington Potter. Dr. Potter is the professor of neurology and the director of the Alzheimer's disease programs at our own Department of Neurology at the Linda Cernick Center Institute for Down Syndrome at the University of Colorado, Denver. He is devoted to studying the relationship between Alzheimer's disease and Down syndrome, and this is in recognition that studying these two diseases together will best hasten the development of new treatments for both. Dr. Potter studied and researched and taught at Harvard University for 30 years. In 1998, he joined the faculty at the University of South Florida as the Eric Pfeiffer Chair for Research on Alzheimer's Disease. He designed and directed the NIA-designated Florida Alzheimer's Research Center at South Florida. And from 2004 to 2009, he was the CEO and scientific director of the Johnny B. Bird Sr. Alzheimer's Center and Research Institute. During this time, the Institute built the largest freestanding Alzheimer's disease research institute in the world and developed 7 new treatments for Alzheimer's disease in preparation for human trials. It is my honor to be on the stage this morning with Dr. Potter, with Ann, and with Tom, and please join me in welcoming them. So again, welcome, and this feels like my living room, and that was the design. We are truly intending to have a conversation this morning, and we're going to start that conversation with Tom and Ann, and talking a little bit about what your experience has been like beginning to live with Alzheimer's disease. And so, Tom, we were hoping that you could start us off by talking us through some of the changes that you first experienced and noticed, and what that's been like for you.
Right. So the initial things that I noticed were basically if I go to a restaurant, I was having trouble figuring out the tip for the restaurant, and that was kind of, well, you know, I used to be pretty good at math. What's going on here? And then the sort of short-term memory loss came after that, you know, going into a room and forgetting what I went there to get, and, you know, things were just kind of bouncing back and forth between rooms, and trying to figure out what I actually went there for and remember what I went there for, and work. That it was really came to a head at work. I mean, I just couldn't perform anymore, and even before I got diagnosed, it was, you know, I was having to work late into the night just to get the same work done I used to get done in a normal work day.
Tom, can you tell us a little bit about the work that you were doing at this time?
I worked for Ericsson, and I was a solution architect. Thank you. This was my job. So I went and met with customers and got their requirements for various IT projects and that sort of thing.
Okay. And one thing that sounds significant, so the tip, for example, you knew that that was different. You had said you were strong in math, you could experience these changes, and you knew something wasn't right?
Exactly, yeah.
Okay. And Anne, as you were watching this happen and experiencing it yourself, what was that like for you?
Well, it was awful hard to watch Tom changing. He was very headstrong, pretty organized, and good at his work, and he would be working until midnight and still not able to finish the tasks that he would usually have done by 5 o'clock. So the evenings were quite different. It was maybe a year and a half ago that we started noticing more and more trouble just at the end of the day. Around dinner time was more stressful, multitasking as the kids are telling a story from the day, and there's a lot of animation and mayhem that might go along with that. It was awful hard for us to have a conversation as well, and then the process of getting food onto the table as well. So very disorganized evenings, and it was stressful. It was especially hard. It came kind of to a head at one time when Tom was on call overnight, which was a common thing. But he was toggling between the customer and coworkers. He had multiple computer screens going, and he was tired. So that was an especially tough evening, and it kind of opened our eyes that we really need to push this a little further with the doctors.
So it sounds like that evening really triggered for you the recognition that something was changing. And just one question, did this happen gradually for you, or what was kind of the sequencing?
You know, it's hard to say exactly when it started, but it's just one of these things that kind of progressively got worse. And yeah, I can't put a, you know, this date, it was this, it just kept coming, you know. It just wasn't getting any better. And we actually went to marriage counseling too for a little while, just to try to figure things out.
Yeah. It didn't seem like we were on the same page, and we weren't sure where it was coming from. So it was actually the therapist that really pushed us to push the issue with the primary care doctor as well. So that was helpful to have that kind of kick in the pants, because it's so easy to dismiss so many of the things that are going on when you have a busy house. Both parents are working and you're trying to keep active with lots of extracurricular activities. It's easy to dismiss lots of the little things that go on. It doesn't seem, it's very easy. Every single thing you can trace back to, well, we were just tired during that time. Right. But when you started adding them all up, it didn't quite make sense. So.
Well, and Dr. Potter, I'd like to bring you in at this point as you're listening to Tom and Anne's story as a physician, as a scientist, or excuse me, as a doctor and as a scientist. What does this sound like to you?
It's pretty typical of families to be confused at the very early stages of either frontal temporal dementia or Alzheimer's disease, because the symptoms can be quite subtle. And we all lose things. We all go into rooms that are familiar with to us, and we don't know why we went there, because we're distracted. We have many, many things on our minds. And so it's easy to dismiss the early symptoms. Especially, it's true that sometimes a person will not recognize the symptoms themselves, but their families will recognize it. So it is a group collaborative effort to recognize when real professional help is needed. And of course, that's what we want to try to develop through the Alzheimer's Association and the university, is the best possible help for people as they grow through the stages of either Alzheimer's disease or frontal temporal dementia.
Right. Well, and I want to go back to, it sounds like your therapist was a significant trigger in recognizing it was time to pursue diagnostic tests, and my sense from what you just said, Dr. Potter, is that the intervention of healthcare professionals, allied health professionals, can be really critical in not only accurate but as soon as possible assessments. Can you share a little bit about what's happening in the research and science world that helps us do that as well as we can?
Right. Well, of course, in any kind of research, there's diagnostic and there's treatment. And scientists throughout the world are trying to develop improvements in both diagnostics and treatment for all kinds of dementing illnesses. One of the great advances that have come recently is the ability to actually look into the brain of a person in real time while they're awake and see the deposits of amyloid, for instance, in Alzheimer's disease, growing even before there are serious clinical symptoms. There are also some blood tests that are beginning to develop, and of course for early onset there are potential genetic tests that can be used to see whether this is a genetic form of the disease or not. This all helps to identify the disorder in the particular person as clearly Alzheimer's disease or frontal temporal dementia, or possibly a vitamin deficiency, possibly Wernicke-Korsakoff syndrome. There are other causes of dementia which have to be ruled out because sometimes they are more treatable than Alzheimer's disease or frontal temporal dementia. So it is very important to have a professional take a look at a person as they're beginning to develop these kinds of problems.
Right. And Tom and Anne, in your experience as you started pursuing diagnoses, can you walk us through a little bit about what that involved and what that experience was like?
So initially our primary care, there you go, the primary care doctor, we went to our primary care doctor. She referred us to a neurologist, and then that neurologist referred us to a neuropsychologist to do a whole testing workup. And I did the whole 8-9 hour test deal, which was pretty shocking to the ego to not be able to do math and to be able to, you know, trace this shape and, you know, what did that shape look like? Can you write it again by yourself? And all these kinds of tests and math tests. And I left there feeling pretty down. That was a tough day.
Well, and after that, so that makes complete sense. That's a lot, and this had been happening in a relatively short period of time. What happened the next day? How did you keep moving forward after that?
Well, we kind of, we looked for a second opinion. I mean, it wasn't, you know, it was maybe a few weeks later that we went to UC Hospital in Denver.
So both our neurologists and other local doctors all were kind of on the fence about whether it was the just a generic mild cognitive impairment or definitively FTD or early onset Alzheimer's. Along the way, we kept hearing about Dr. Bruce Miller is in University of California, San Francisco, and he's a guru for FTD. All of Tom's family's in San Francisco. We were planning to be there for Christmas anyway, so we made an appointment with them, and that really helped us to get even more information. And they also directed us to a research study.
Right.
And we came back a few months later, and after about a week of testing, it was narrowed down that it really, Tom didn't have some of the behavioral changes that go along with FTD, but more and more short-term memory and visual spatial issues were coming up that had it look like early onset Alzheimer's disease.
Okay.
Yeah, and I forgot what I was going to say. Yeah, about the study. So, and we just recently got confirmation from the study that they found amyloid plaque deposits. So, that,
From a brain scan.
From
yeah,
a PET scan.
PET scan, yeah.
Yeah, that's a very important new addition, and it's now available not only in research centers, but there's an FDA-approved PET imaging agent that can be used. Of course, without new treatments that are really effective, it's merely confirmation of the suspicion of the neurologist. But you were in the hands of very good people.
Well, and we're going to come back to research in just a moment. But Dr. Potter, Tom is experiencing at a very young age early onset. And could you share with us a little bit your thoughts regarding his experience, Anne's experience, and how it applies to other related dementias and people who maybe are more progressed in the disease process?
Right. We like to think of Alzheimer's disease as a universal problem. It does affect people as young as 48, even in the genetic forms as young as 30. But it also, of course, more commonly affects people who are in their 60s, 70s, and 80s. If everyone in this room lives to be 85, of course, half of us will have Alzheimer's disease, and the other half is probably going to be a caregiver of one sort or another. So we're all at risk. You're just one of the unlucky ones to have, revealed this at an early age. So one of the things that we're realizing is that the early stage of Alzheimer's disease, which used to be the only kind of Alzheimer's disease, for 50 years, Alzheimer's disease was considered an early form of dementia. Now we understand that what used to be called senile dementia, when my grandfather had it, is actually a form of Alzheimer's disease, and they should be considered in the same pot and studied together. Of course, the early onset form has been a tremendous research insight because that tells us that there are genes involved, and we can study the genes, and we can develop mice that get Alzheimer's disease thanks to those genes. So it's been a real collaboration between patients, their caregivers, their families, the Alzheimer's Association, the scientists all over the world. Together, we've been able to understand a lot more about what's going wrong and try to begin to develop drugs that are not just helping the brain cope and function a little better, but may actually begin to reverse the disease process.
As you talk about the genetic testing available and research around genetics, it makes me think of family history. And so I'd be interested in hearing both Dr. Potter, from your scientific perspective, a little bit about the role of family history, and then Tom, also a little bit about your personal family history.
Why don't you go first?
I'll go first. So my father had Alzheimer's disease, and his mother had some form of dementia also. I probably could have been Alzheimer's, but they didn't really diagnose it back in those days. But when we went through the research study in San Francisco, they didn't really make a connection.
So they tested you and didn't make a connection?
They did. They didn't see the what's that typical marker for the gene
Well, they
marker?
can look for ApoE4. That's one of the genetic markers. And they could have looked for a mutation in either the presenilin gene or the amyloid precursor gene. Either one of those could have given them a hint of what kind of genetic form you might have had. But there is a whole set of genes which we haven't studied well enough to say whether they're a risk factor or not. Overall, we can say that about 70% of Alzheimer's disease is genetic. Now that's bad for people who have a family history like you do, but it also means that 30% is due to some kind of environmental effect. And that may be more modifiable. For instance, coming to meetings like this and getting educated is stimulating to the brain, and that helps delay the course of Alzheimer's disease.
Well, and as you use the word modifiable, and there's a lot of attention being given to modifiable lifestyle factors that can help either buffer or perhaps delay progression. Can you talk a little bit about some of the things that are happening, both science and research-wise, around modifiable lifestyle factors?
Sure. Unfortunately, there are many more claims for modifiable risk factors than there are facts. But the facts are fairly clear that exercise is one of the best preventative measures that you can take for either Alzheimer's disease or heart disease. I think that we often say that what's good for the heart is good for the brain, and that's true for many different reasons. One of the most obvious ones, of course, is that if you have high cholesterol and high blood pressure, then you're at risk for cardiovascular problems, and those can affect the brain as well and give you vascular dementia. So if you get rid of that entire problem by getting more exercise and reducing your blood levels of lipids, then you're going to be benefited not only in your cardiovascular life, but in your brain life. So that's one example. There's another example which I sometimes use because I don't drink coffee, but it turns out that coffee actually can cure the mice of Alzheimer's disease. So we're studying that, and we're going to look farther into it. So that's something that could be a risk factor reducer if we want to look at it more carefully. But more research has to be done to be sure about that.
Well, and as you talk about exercise, I know, Tom, you have shared with me that exercise and enjoying our beautiful outdoors here in Colorado has always been an important part of your life. Can you share with us a little bit about how you've continued to not only engage in physical activity, but just in general in the things that you love and that are important to you and your family?
Yeah, excuse me. I would say exercise is a big thing. I mean, I still, we both exercise, and that's something I can do positive for my body. You know, even though the Alzheimer's disease is ticking away at that, it's something I can keep doing, and I'm going to keep doing it as long as I can.
And I'm curious, do you, Tom, feel when you exercise, either immediately after, or it sounds like you are an avid exerciser, how does that make you feel in the art? Can you notice differences at this time?
I do. It's more if I don't exercise, I don't feel good.
Okay. That's
yeah.
That's an important point, I think. So, okay, very good. And Anne, you're as a care partner, clearly not only on this journey with Tom and your family, but when you look at your health and well-being, I heard Tom say you exercise a lot as well. What role has that played for you?
Oh, it definitely is very mentally cleansing. We met when we were mountain biking in Colorado. Tom's from one side of the country and I'm from the other, and the outdoors have always been a big part of our life, and to be able to get the kids up to the mountains makes a big difference in our emotional health. It feels very positive, and to have that connection with nature. When Tom goes away for the day, he comes back a much refreshed person, easier to connect with everyone, and just happier. So that's a big part of our lives. We took the kids on a big road trip this summer to a lot of the national parks in the West, and that was a hoot. Traveling is a big part of our lives. We met over a discussion of travel, and so we were able to go to Croatia over the summer and get some great sightseeing in and do a bit of hiking while we were there as well.
Well, and so it sounds to me exercise, travel are things that you've always loved, and you're remaining engaged. And it makes me wonder, Dr. Potter, what role engagement plays, either as a modifiable risk factor or just in general well-being. We'd love to hear your perspective on that.
Right. It's a chicken and egg kind of problem, because people who are active in their lifestyle tend to be more engaged, and people who are more engaged tend to have a lower risk of developing Alzheimer's disease. So we don't really know whether the engagement is a reflection of the health or disease characteristic of the brain, or whether it's something that can actually be modified. Now, in the mice, if we put them in what we call the Club Med cage, where they have other mice to play with, and they have running wheels and mazes, they get better. And the societal interaction with other mice seems to be part of that. But translating that into human behavior, of course, will take more experiments, which many people around the country are doing. But coming out of that, as we mentioned, exercise seems to be particularly important. But the other thing, of course, is that in order to generate mice that we can study for Alzheimer's disease, we have to change their genetics, which we're able to do. And that gives us real insight into how you develop new treatments, for instance. You can try the drugs in mice before you try them in humans. The other thing we've noticed is that people with Down syndrome, of course, as many of you know, all get Alzheimer's disease in their brains by the time they're 30 or 40, and at least half have dementia by the time they're 50 or 60. So this is a very special human population that we at the University of Colorado are going to be particularly studying because of its potential insights into typical Alzheimer's disease. And of course, the reason they get Alzheimer's disease is because they have 3 copies of chromosome 21 in every cell, and that means they have 3 copies of the main Alzheimer gene in every cell instead of 2 copies like everybody here has. So that's extremely interesting, and the fact that you were not sure whether you had frontal temporal dementia or Alzheimer's disease is relevant, because one of the things that we found was that people with typical Alzheimer's disease, and we've just discovered it for frontal temporal dementia also, develop Down syndrome-like cells with 3 copies of chromosome 21 in their brain, in their blood, in their skin over the course of their life. So they actually become like, a little bit like Down syndrome, but not that they were born with it, but they develop it over time. And this is a new connection between frontal temporal dementia, Alzheimer's disease, and Alzheimer's Down syndrome that we never knew before, and gives us a new insight about how to try to approach developing new treatments. So you're not unusual in the sense of not knowing for sure what you had until it progressed a little bit longer, because the diseases are really related in very interesting ways.
Well, and Dr. Potter, you just gave a great example of a current research development that you're working on here specifically at University of Colorado, Denver. I've heard you say before that researchers need collaborators. Can you tell us a little bit more about what you mean by that?
Sure. Well, we have a perfect example here of 2 collaborators in research. And everyone in this room can be a collaborator too, because without the help of the caregivers and the patients and the supporters, we can't do our research. We love our mice and we love our patients, but without patients to help and without support for the research, we can't do the job. So that's what I mean by we're all in the boat together. We all are at risk of developing Alzheimer's disease, and we're all collaborators in the scientific exercise to try to find a new cure.
Well, and with that, both Tom and Ann have made reference to the research that you have participated in through University of California, San Francisco, correct? Anything else you want to share with us about that experience? And because researchers do need collaborators and we all need collaboration, maybe if you would share, why were you open and willing to participate?
For me, it's a twofold thing. There's to help the general population, that may get Alzheimer's or already has Alzheimer's. And then there's the selfish part that, I want to stay around as long as I can for my kids, because I have 2 5-year-old kids. So that's kind of my biggest motivator, being there for those kids when they grow up and being able to be an active participant in their lives.
Right. Well, and Anne, my sense from our previous conversation is that's been a big factor for you as a care partner, as a wife. What has the research experience been like for you?
Yeah. That was a rough week. Tom, the spinal tap was a little hard on Tom. He had a headache for a long time afterwards. Phenomenally emotionally draining to have hour after hour of cognitive testing. But it felt also very positive and good to be there and contributing to hopefully the next generation of drugs, of treatments. It definitely is hard when, especially, we're lucky in some regards because our kids are adopted, so we don't worry about them inheriting it more at a more likely rate than others. but when I see other young families, because the Alzheimer's Association has been phenomenal about fostering connections with other families that are in a similar boat, and to see those kids that are biologically from their parents, and to know that they're much greater risk for developing some of the dementias, and to know that we might be part of making some changes for those kids is very impactful. You know, for us, I think for our kids, we're going to keep plugging along and doing everything that we can to stay active and take care of ourselves, and keep the kids as along of a normal path as possible, with the hope that maybe this contribution that Tom is making would generate some changes so that he will have some treatment, so that he can be there throughout their lifetime. So.
Dr.
One of the things that is going to change very soon, and is changing now already at the University of Colorado, is that instead of having to go to San Francisco to participate in a clinical trial, we have a memory and dementia clinic just set up at the University of Colorado here in Denver. It's headed by Jonathan Woodcock, who is doing a workshop this afternoon. I recommend that you go to his workshop. We will be building essentially an entire Alzheimer's center focusing on typical Alzheimer's disease, including frontal temporal dementia, and especially people with Down syndrome, right here in Denver. So people who want to participate in research either as a support or participant can do it right here in Denver. And we will need normals as well. So people who know that they're healthy, and especially if they want to eventually donate their body to science when they do die, that will be very helpful and useful as a participant, collaborator in the research right here in Denver.
Well, and that's a phenomenal resource to have here in our state and in our local community. Dr. Potter, as the audience hears that, if someone were interested in learning more or possibly exploring participation in research, what would be the first steps? How would they get involved with that?
Well, probably call the clinic, the Memory and Dementia Clinic at the university. That would be the best start. Okay. We will be carrying out not only interventional research, such as, and I'll tell you about this in a second, a new drug that we've developed, but also longitudinal assessment, because you're a particularly valuable research subject because you had very good clinical assessment early on, and then you're going to follow your progression over time, and that kind of progressive analysis is very important, not only for people with challenges like yourself, but also with age-matched normal people, to see the difference between people who have challenges and people who don't. I mentioned the clinical trial that you participated in, the clinical research, and one of the ones that we're working on here is based on the fact that people with rheumatoid arthritis tend not to get Alzheimer's disease. They're about protected maybe tenfold. So that was a very curious fact, and we started to look at why it might happen, and to make a long story short, we found something that is released during rheumatoid arthritis that, when we injected it into the mice, essentially turned the mice into normal mice when they had been very clearly demented. And the lucky thing is that it's a FDA-approved drug for bone marrow transplant patients, so it's totally safe, totally known already, and now we're starting a clinical trial probably in 3 or 4 weeks, I hope, here in Denver to test it in people with Alzheimer's disease. It's a totally new approach, not tried before, and is very hopeful.
Well, how encouraging not only to hear about that research going on, but particularly that it's happening here in Colorado. So any other updates? I mean, clearly that is amazing information. Any other research or science updates that you'd like to touch on, Dr. Potter?
Well, I touched on the relationship between Down syndrome and Alzheimer's disease. That's giving us a hint about why those plaques in the brain, those A-beta deposits, are hurting nerve cells. And so if we add A-beta to nerve cells, they stop functioning correctly. Their ears and eyes aren't working correctly. And that may give us a hint about how to prevent that by making a small molecule or looking for a drug that would just prevent the A-beta peptide from hurting the nerve cells. And again, we will do this first in test tubes and tissue culture dishes, and then finally into the mice before going into the clinic. So in order to have a good research program, you have to have everything in one place. And so the scientists and the physicians and the patients and the caregivers and the mice can all talk to each other.
Very good. I think what we're going to do is, if it's okay, Anne, switch a little bit to what the experience has been as a care partner with Tom. Can you share with us not only that experience, but I think we'd really be interested in knowing what has been particularly helpful, what perhaps has not been helpful, and as we have many caregivers here today, what are your words of advice that you could offer all of us?
Well, definitely the reason that we're sitting here is because it's an opportunity to give back to the Alzheimer's Association. After one of the first neurologist appointments, I drove right to the Alzheimer's Association. It was still vague as to what the diagnosis was, but I'm a physical therapist and I know of their reputation in the community, and so I knew that we were in good hands. So I use their library. I read every book on whatever the current diagnosis of the moment is. As well as we go to the support group, which has been phenomenal. It's great for the early onset, younger onset. Tom meets in one room with those that are diagnosed, and I meet in another room with the care partners. And it's a nice way it's a nice structure so that we're both getting different things out of the time. And also through that, we've been able to meet other families and make some more connections. Just a few days ago, a group of us met at the Active Minds event at the Tattered Cover, and it's a great lecture series. And then went out to dinner, and it just feels good to see other people that are in a similar boat being very positive and carrying on and just plain enjoying themselves. So it's a fun way to keep going. So that's been a big support for me. As strange as it sounds, something that's not supportive is when we'll have friends sometimes that will say, "Oh, Tom looks good." Well, boy, he looks fantastic, and he doesn't look sick. And as strange as it is, it feels very dismissive of anything that he's going through because it is an invisible disease and it's not right there on his forehead. It doesn't inquire into learning more about what's going on in our lives or ways that we might need help. Or so that's, as strange as it seems, the harmless casual topic of, wow, he looks fine. It doesn't feel very supportive. So.
And I heard you say the word dismissive, and I would imagine that, while unintended, that if things like "you look great" feel dismissive, that makes sense. And are there other examples of that for us, not only as care partners but professionals, where something has felt dismissive even if you know it wasn't intended that way?
To be honest, I can't think of another example, except when things are just generally glossed over. I think it's easy when you're in the community and you're caring about to make it seem as though things are going okay. But it is the little heartfelt when someone looks you in the eye and says, "Really, what do you need today?" Or to bring it down to a very concrete moment that it makes a massive difference in going about the week successfully. So
I think that was a really powerful example of something that's helpful. The eye contact, the sincere, genuine, "How are you? What can I do today?" What are some of the other things that you found, Anne and Tom, that have been helpful, that have been supportive?
I guess with me, I have a hard time digesting people's well-intentioned. Sometimes it's too much, and that kind of gets me. I don't know. I grew up in kind of a stoic family, so too much input from people, well-intended, sometimes is not helpful.
Okay.
Yeah, you've often commented afterwards that it felt like they were just pouring pity on you rather than actually checking in with you.
Well, and one thing that strikes me is, just as Dr. Potter was talking about how important it is to have collaborators in research, when you described going to the tattered cover and getting together socially, it sounds like there's a collaboration happening among care partners. Is that a fair statement?
Oh, definitely.
And it sounds like that collaboration, by making connections and specifically the help of the Alzheimer's Association, has made a big difference to date, and I'm sure will continue to do so. Anything else tied to your experiences? You talked about one of the first things you did was come to the association, getting involved with the support groups. What else, if anything, would you like to share about what the association has meant to you in this experience?
You know,
Go ahead.
they, during the diagnostic process early on, I called the helpline. And I can't remember the fellow's name, but he was phenomenal at keeping me going and focused on what we need to, the appropriate questions to ask, and it really got us through the diagnostic process. He was great. And then when we did stop into the Alzheimer's Association, they definitely emphasized financial planning, legal planning, and we would not have done that without a kick in the butt. So that was a good thing to have that kind of under our belt now. Definitely felt good and gave us a lot of resources for where to go about doing that.
Very good. Well, and one of the things that you certainly both talked about is part of your desire and commitment to being involved with research and reaching out to your resources has been your children, and your desire to be here with your children to look at things that can help them and future generations hopefully not experience the club that you've found yourselves now a member of, that you didn't set out to join. Are you open to sharing a little bit about what the experience has been like for your 2 5-year-olds so far?
It's hard to say. I mean, I don't think they quite grasp it yet. They're just a little too young. I mean, they know that I have some sort of illness, that a chronic illness, but they don't understand the sort of vaster significance of it.
Yeah.
Not yet.
We've put some words to it, that Tom has trouble thinking through things, and it does come up, but it's not a glaring part of our lives, and we're going to approach it as we're a family, and we're a strong family, and that's what people do for each other in the community, and we're there for each other, and everyone has something that they're going to come to grips with, and these kids are going to learn different skills that other kids aren't going to, and I think it's going to be, and Tom's a phenomenal role model and is very, very committed to the kids right now, so we really structure the day up so that he has a lot of energy for them at the end of the day, and for the weekend activities, so that advanced planning for structuring out how we're going to allocate our resources, and getting a lot more comfortable with asking a lot more people for help, and that's not something that came easy. So definitely family and friends have been there in ways that we wouldn't have anticipated needing people, but they've just been great and want to be there, so we're very lucky. It's just more of a mindset change that we're accepting that. So.
Well, and Dr. Potter, as you hear the story of Tom and Ann and their family and their children, as you connect it to your day-to-day experiences in the research and science world, what are your thoughts as you're listening to their story?
Excuse me. I think the most clear thing is that in a way you're lucky to be relieved of the concern for your children that so many families with Alzheimer's disease have. You know, the sad thing about, say, somebody with Down syndrome who will develop Alzheimer's disease in their 50s is that their parents, who are their caregivers for their life, will very likely not outlive their children, And so then that child will have Alzheimer's disease with no one to support them. So this family connection goes through the entire problem of Alzheimer's disease, frontal temporal dementia, Down syndrome, because there are no easy answers, and every family has to deal with it in a special way. So you're relieved of one stress, but I'm sure you have others that are even worse in some ways. One of the things that I find when I'm talking to a person with Alzheimer's disease is that, you know, they're people like anybody else. And even if they're not quite as quick in response in a conversation, they like to participate in conversations. So it's very good that you're getting out into, you know, the public, and, you know, Tom isn't retreating. And that's very important both for people with Alzheimer's disease and people with Down syndrome, that they don't need to retreat. We don't have to say, oh, I'm embarrassed that, you know, a person in my family has Alzheimer's disease. It's not their fault. It's nothing they can do about it. And they're people just like all the rest of us, but with different characteristics. And that's fine.
Well, and with that, we've touched on the personal experience, some of the science, and some of the exciting new developments. Tom, you've shared what it's been like to actually be a participant in research, and we're putting a call to action out for research collaborators. With that, let's talk and shift to the future. And Dr. Potter, if it's okay, I'd like to start with you and ask you to share some of the things, building on many of the updates you've already given us this morning, but where do you see the future, both from a research perspective as well as how what we're learning in science can make significant day-to-day differences, positive differences in the lives of people like Ann and Tom?
Right. Well, I'm personally a very optimistic person, and I couldn't be in science if I weren't, because at least 90% of the experiments we try fail. So you have to keep yourself going every day that you're going to make a difference in one way or another. And as I mentioned before, we have to have collaborators. So the reason that I'm in Colorado and not in Tampa, where there are many more patients, is that the support here was better. We have the Linda Cernick Institute for Down Syndrome at the university. We have the neurology department at the university, and we have the Alzheimer's Association, and the collaborative instincts of these three, you know, groups is much higher here than I've seen in many places. So that's a very hopeful thing for the future, at least here in Denver. The other thing is that scientists like to talk to each other. And every time we go to a meeting, every time we open up a journal article, we're basically communicating with other scientists or making discoveries that we may be able to build on. So for instance, we could never have discovered this potential for leucine, this drug that we're looking at now, if we hadn't talked to people who were looking at people with rheumatoid arthritis. I mean, no one had the thought that rheumatoid arthritis would have anything to do with Alzheimer's disease. And until fairly recently, it wasn't thought that people with Down syndrome had anything to do with people with Alzheimer's disease. So the future is very good because of these communications, because we're building a focused approach that is taking the knowledge and the insights of many scientists and trying to apply them to this very serious problem that is going to, you know, break all our hearts and break all our bank books at the same time. So that's very hopeful. The other thing I can say from a scientist's point of view is we know much more about Alzheimer's disease now than we ever did before. And there are many, many new approaches that are being tried to combat the disease. Very early intervention may be critical, because by the time clear symptoms are there, a lot of damage has already been done, and we may be unable to reverse that damage. So we need to start early so that we can prevent the disease. Of course, any preventative is likely to help somebody who already has it, but starting early is going to be very important. So this kind of recognition is important. The other thing is that the legislators, both in Colorado and nationally, are beginning to wake up to the fact that their constituency is very concerned about Alzheimer's disease. And we need to solve this problem now. We can't wait until it's a complete catastrophe. We have to start now. And so there's a national thrust for Alzheimer's disease. Hasn't been funded yet, so talk to your congressman and senator and tell them that they really need to put some money behind this. But the interest is there, and that's something terribly important. And of course, the Alzheimer's Association, the Linda Cernick Institute, the university, not only here in Denver, but throughout, are helping educate legislators to realize that it's in their power to help us. And they need to do that.
Well, and we haven't really touched on policy yet, but as you make reference to the National Alzheimer's Act that was put forward, from a scientific view, as you look at that, clearly the focus and attention at face value is important. But as a scientist, are any thoughts just in general on policy or the specific national act?
Well, the act is a very important first step, but it's only a first step, because without the oomph behind it, the actual gasoline, you can't move the car anywhere. So it's a first step, and the concern that I might have, if I have any at all, and that is that once passing the Alzheimer's Disease Act, then they say, okay, we've done our job, that's all we need to worry about. We've called a press conference and we've made some noise. That's only the first step. You have to put some dollars behind it.
Very good. Well, and Anne, as our time is quickly coming to a close here, it really has felt like just being in a conversation in our living room here. As a care partner, if you could share any of your, not only closing thoughts, but really as you look out onto our audience, what advice might you offer over in addition to what you've already so generously shared this morning?
I guess I would hope that there were more changes within the community to support this younger onset. It's definitely a unique situation to be promoting the kids' health and happiness as well as the families, and to be there as much as possible for Tom. So there's a lot of momentum. We're very lucky in this community that there are a lot of active people within the younger onset group. So I think that some changes are going to be coming about. So that the community is more ready to support and has more tools to be able to concretely be there for this population.
Very good. And Tom, again, our thanks for your willingness to share your story. What else do you want everyone to hear this morning, or advice that you might have both for professionals who are working to make a positive difference, as well as family members and care partners?
Excuse me. I would say just keep living life. Keep doing things. Keep being active. Keep meeting with friends, getting together with people, doing activities. One of the things I'm finding difficult but therapeutic is I'm learning to play piano. And that's
for the
good
first
for the brain. Yeah.
That's
so
awesome.
I forget who it was. Somebody said there's anecdotal evidence that you can regenerate or grow new synapses. Yeah.
Cerebellum is less affected than other parts of the brain, so you might as well make use of it, which you are in your exercise. And piano playing is similar to that. It's a very interesting idea.
So it sounds like there are some piano concerts and recitals ahead for all of us here, which is wonderful.
That might be a few years out.
Well, I think just at least as I hear that, I mean, it's so incredibly inspiring to hear as one of the themes you've shared is, in light of all of this change, that again you didn't invite into your lives, but you're looking for what can you build from. And I think that's a theme that not only Tom and Anne have shared with us this morning, but Dr. Potter has given us, I think, reason to continue to have hope and optimism that the science is moving forward, specifically some exciting things here happening in our own area, And with that, I want to, I guess, give one opportunity to have each person close out with any final thoughts.
I would just say, stay active, really. Stay active, participate in things, go to events, go see concerts, go to the pub with your friends one night of the month, just keep going forward. I mean, I
think you said it beautifully. Live life. I heard you say that.
Yeah.
Very, very great. And
I just thank Dr. Potter and his team and hope that money and enthusiasm keeps coming his way. We're looking forward to Tom being there for the kids. We want to be able to take them back to their birth countries of China and Taiwan, and Tom wants to be able to climb the highest peak in each country, so that's a big push for us to stay active and maybe play some piano over there.
Awesome.
Wow, that's great. I mean, I don't know what I can say except to thank everybody for coming, because getting the word out is at least half the battle. People have busy lives and they have other interests, but this tsunami of Alzheimer's disease is really going to wreck the world if we don't solve it. And so get the word out and tell your friends about Tom and Ann and what their experience is. Everybody's life is a little different. Every Alzheimer's person is different, and they all need help, and we're here to try to help, but we need your help too in terms of getting the word out. Thank you.
Well, and in terms of getting the word out, earlier Dr. Potter made reference to Dr. Jonathan Woodcock, who is here today, and Dr. Woodcock is going to be presenting a breakout session today called Mythbusters: What's True in Alzheimer's Research Today. And that's going to be one of the 2:15 breakout options. And with that, to all of you, we want to just sincerely thank you as we look from here out on this absolutely jammed full, large room. It's really a testament, I think, to the sense of collaboration to work together on strategies that can make a difference as science advances, and how that can translate and be applied into the lives of people like Tom and Ann, who have so generously shared their story to you, and everyone who has joined us this morning. So we thank you for attending the symposium, and thank you for your support of being here today. I would like at this point to ask that anyone who's attending the early stage forum, you can go ahead and leave the room now, and you can look for volunteers in the orange shirts. Can we see the volunteers? Shout out to the volunteers. Look for our volunteers, and thank you to our volunteers as well, who are going to be guiding us throughout the day. If you're attending the early stage forum, please go ahead and they can get you to your sessions. And we're now going to take a break until 10:30 when the first breakout sessions start. The exhibit halls are here. Please go and meet and learn about our sponsors. And again, please join me in a round of applause for Tom and Ann and Dr. Potter. Thank you so much.